Good afternoon, everybody. First of all, I would like to thank the organization for offering me the opportunity to tell something about my experiences as a surgical resident in Malawi. In 2010, I was in my 5th year of surgical residency in Arnhem and Nijmegen, eastern part of the Netherlands, and I was offered the opportunity to spend 3 months working at the Queen Elizabeth Central Hospital in Blantyre, which is the economic capital of Malawi. And because my wife likes adventure, we decided to go there and take our children of 2, 4 and 8 years old with us. Our trip to Malawi has been very impressive for all of us and instructive for me as a young surgical registrar. I can truly say that my family has fallen in love with Malawi and its people. In this talk, I will summarize the Dutch regulations with regard to doing part of your specialist training abroad. Furthermore, I will describe my time as a surgical registrar in a low-resource setting, summarize my experiences, and focus on the necessary preparations that need to be done before undertaking such a journey. As you all know, Malawi lies in between Tanzania in the north and east, Mozambique in the east, south and west, and Zambia in the west. It is a republic and was a British colony until its independence in 1964. Most people speak English, but Chichewa is the most used language. Malawi is one of the poorest countries in the world. It has no minerals, little industry, and the economy is heavily based in agriculture. And 85% of the population lives in rural areas. The main industries are tobacco, tea, and sugar processing. And 90% of the Malawians have an income of less than $2 per day. When comparing Malawi to the Netherlands in crude figures, you can see that Malawi is about 3 times as big as the Netherlands with less inhabitants. And due to high infant mortality, the average life expectancy is only 50 years old. It's estimated that about 12% of the population is HIV reactive, as they call it, as compared to only 0.15% here in the Netherlands. Furthermore, there are about 500,000 to 1 million orphans in Malawi, as compared to still 34,000 orphans in the Netherlands. And here orphans are defined as children who lost at least one of their parents. And the mean annual income is $348 in 2010, that was, as compared to $45,000 in the Netherlands. The regulations for specialists training abroad have been set by the Dutch Registration Committee for Medical Specialists, the RGS, and stated in 2008. And these terms apply to all specialties, not only to surgery. In summary, the undertaking should have a well-described goal that fits the training plan. The level of clinical training has to be at least similar to that in the Netherlands. The hospital should be qualified for specialist training and education in the country you are visiting. The registrar should be supervised on a regular basis, and finally, the registrar must be licensed to work as a doctor by the local authorities. And when all requirements are met, importantly, your local tutor back in the Netherlands should approve the training plan. When he or she does not approve, you may not go. And if this is done, Dutch residents are allowed to spend a maximum of 3 months abroad. Finally, there are no specific regulations with regard to training in a low-resource setting. I worked at the Queen Elizabeth Central Hospital, which is a large hospital that is affiliated to the University of Malawi. It has approximately 1,000 beds, but it is estimated that 1,200 patients are hospitalized. The mortality rate is about 10%. It's 10 patients per day, equaling about 1% of the hospitalized patients every day. It is estimated that approximately 30% of the hospitalized patients are HIV reactive. The hospital has no emergency department for adults, but still one for children, where an estimated 100,000 children are seen every year. Most children are seen for malaria. Finally, our Malawian colleagues still have the time for medical research. My last PubMed search for publications from the Queen Elizabeth Central Hospital resulted in 359 papers since 2005, 13 of which were published in The Lancet. In 2010, there were 9 Malawian, American and German surgeons working at the Department of Surgery. Further, there were a couple of clinical officers who, after 4 years of clinical training, were able to carry out a whole bunch of surgical procedures, including inguinal hernia repairs, laparotomies, and bowel resections. Finally, there were about 4 to 6 registrars and 4 to 6 interns. And as you can see, the wards were big and in the beginning very unclear to me. This is, by the way, my tutor in Malawi, Professor Borgstein. He is the only pediatric surgeon in Malawi who has lived most of his life in Malawi, actually, speaking Chichewa nearly fluently. And here he's standing to, who knows? I didn't see it, but it was Madonna, the pop star who adopted a Malawian child in 2006. The hospital had a total of 10 operating rooms, of which 5 were available for the Department of Surgery. However, when I was there, 2 operating rooms were under reconstruction, so that only 3 rooms could be used. There were 3 anesthesiologists, 2 registrars over there, and several clinical officers providing anesthesia. The ICU had 4 beds, 2 of which were equipped with ventilators, which were quite dangerous, actually. I have seen many patients with some impressive surgical pathology. Although oncological diseases were relatively rare, these were practically always in an advanced stage. Furthermore, I learned to take clinical decisions based on history taking and physical examinations only, since the hospital did not have reliable radiological aids. However, I must admit that this was not particularly difficult, since patients with abdominal pain usually had an acute surgical emergency requiring laparotomy. I've seen several cases of bowel strangulation, sigmoid volvulus, and incarcerated hernias. I performed or assisted in a total of 124 surgical operations for inguinal hernias, hydrocele, abdominal emergencies, and several limb amputations. I performed 94 operations alone or under supervision. Doing so, I learned some new techniques for bowel anastomosis or for the repair of inguinal hernias. This increased my self-confidence considerably. As you can see, as you know, many patients were HIV reactive. Therefore, several means were utilized to reduce the risks for healthcare personnel, for ourselves. So we used protective eyewear and double gloves at all times. And furthermore, scalpels were handed to each other in a kidney bow. And when possible, we used diathermia instead of scalpels. In the hospital where I worked, there were rapid blood tests available, as well as post-exposure prophylaxis, so-called PEP. And when not available, one should consider taking PEP with you when working as a surgeon in such an environment. I took my family with me, as I mentioned, including my wife, who has worked as an anesthesiologist at the Queen Elizabeth Central Hospital, and our 3 children of 2, 4, and 8 years old. So the oldest child was at the school age when we went there. Some important family matters, including medical issues, have to be addressed. We gave our children malaria prophylaxis. obviously, and had them vaccinated against hepatitis A, B, rabies, and typhus. We sent our children to a British international school that was available there. When children are of schooling age, this is obviously obligatory in the Netherlands, so we arranged everything before leaving. And last but certainly not least, the housing should be settled, preferably before arrival. This may include the need for security guards during the night, which was necessary in Blantyre. And still, with one security guard, we experienced an attempted robbery in the middle of the night, which was very frightening. Ladies and gentlemen, I would like to conclude that surgical training in a low-resource setting is possible and will be a life experience not to be forgotten. The primary purpose, in my opinion, should be to learn, not to teach the local doctors or clinic officers. They were very experienced in the place where I went. And good preparation is essential, especially when taking one's family with you. Thank you for your attention.
Well, thank you very much for sharing your experiences with us. It must have been a very exciting time. And is there anybody with a question for Dr. Koppe? In the back again.
Just a short correction to your presentation. Blantyre, the Queen Elizabeth Hospitals had a Dutch surgeon, at least one, since 1960. You don't mention the Dutch...
He is Professor Borgstein, I think.
My father was there before him, and there have been continuous a number of surgeons. Some of them are probably in the room here, who have worked as well. So there's been a continuous Dutch surgeon since. And my brother is in Malawi, and he's still Dutch. Perhaps that's why you didn't mention it in your talk. Okay. And I just want to add that once you've worked in the Queen Elizabeth Hospital, you can work in almost any other hospital in the world without any problems. At least in my personal experience.
Well, thank you. It seems that the family of Borgsteins is taking over the entire healthcare in Malawi, but thank you for that as well. Any other questions or remarks?
I have a small question about detail. You mentioned the number of orphans in Malawi. You counted them. And I wonder, what is the sense of it? You know, in Holland we have the smallest unit of a family, which is one father, one mother, and one child. In the rest of the world, we don't even have a word for gezin, which is that small unity. The family, the extended family, is the family. And when a father or a mother or both die, the child is automatically incorporated in the rest of the family. And I am afraid that we, from the Western world, create orphans there. And I tell you what, I was working for 3 months in the tsunami in Aceh, and I was asked by UNICEF to count the number of orphans. And we examined roughly 10,000 people. And I asked everyone, do you know of an orphan? Do you have an orphan? Is there an orphan? There were some children who said they are no orphan because the uncle has adopted a grandmother, sister, or whatever, you know. And I came back in Holland, and I was so surprised that on the television there was a big action, and we got an orphanage in Sri Lanka because there were so many orphans. I think we create orphans.
Well, that's an interesting remark. Anybody who would like to comment on that? Is it on the orphans? Anybody who would like to comment on the orphans? I might think it's right. Of course, we all think that we're improving healthcare, but we should be aware that anything might have. If you take an action, you have 3 possibilities. You improve the situation might remain the same, or it might worsen as well, and we should take care not to let the last thing happen.
Your remark about the extended family in other countries than Europe is quite true. On the other hand, when you look closer, you can see very often that the child who is not from the same, very same family, the child doesn't have a mother, if the child doesn't have a father, but it's the stepfather, they are being treated differently. For us from the outside, it's very difficult to make the distinction of how this child is being treated. But I've seen it myself in Africa that yes, you do have the extended family, which seems a great concept, and it's working very well in many cases. But there are enough cases where it's not working, and that the child who is not born or where the mother is dead and it's just taken to the aunt or to the uncle, they are being treated very differently. They are very often neglected. They don't have their school fees paid and other things. It's a very difficult topic, and I'm happy if the extended family works. It's a great concept. I'm happy for every African, every Asian who is living it, but there are others too.
So there might not be really orphans, but they might be kind of Cinderellas, if we all remember the story. Yes, I think one more last question, for we have to be ready for the last general session in 15 minutes.
Is it about surgical training?
Yeah, I'm from European Union Doctors, and I wanted to ask about the training for young surgeons or young residents in this special topic, let's say tropical surgery. Is there any structure program or a training program for the tropical surgeon? I know about some master second level in Italy for the tropical surgery. They they do some programs theoretical and then send for 1 month in Africa. But I don't know exactly if there are some other programs or some other training programs in Europe or somewhere else.
Maybe if I may answer that question. From January 1st of this year, every resident starting the training is only accepted when he has an outline program for himself, discussed with his trainer, and the hospital is supposed to have a training program for the 9 months that he will be there. And it includes all parts of interest for surgery, the first aid, the outpatient clinic, the ward, and of course the operation theater. And there has been a vivid discussion between quality and numbers. For some people think that it's sufficient when the trainer says that the resident is qualified to perform, for instance, hernia surgery. But on the other side, I think very people will be so gifted that they will be capable of performing hernia surgery after having done it only once. So I think it will remain a topic between the figures and quality. But in the end, there's a complete program we embarked on, and the intention is that residents will reach level 3 of performance, meaning that they can do a procedure with limited supervision, and then in the 6 months they will spend abroad. They will have to move on to level 4, being able to do it completely independently, or even level 5, meaning that they are able to teach it to others, if that answers your question.